This is an adaptation from the Guide to Physical Therapist Practice from a book chapter I did with Darcy Umfred in her textbook, Neurological Rehabilitation. You'll notice that related to differential diagnosis, there's two phases. The first phase is kind of the bottom line phase, the bottom line decision. Am I comfortable treating this patient? Do I need to refer this patient? Or do I do both? And that's the third option, to treat and to refer. Now, if my decision is to refer, then my next decision, level of decision, is how urgent do I believe my health concerns are? Is this an urgent referral or not? Now, if the decision is that I'm comfortable with the examination findings and I'm going to go on and treat this patient, then I go on to the second phase of the differential diagnostic process. And this is where I'm putting the patient into a syndrome, their findings into a category. I take the cluster of findings, and that will help guide me in terms of the specific treatment program, the prognosis, and what I'm going to assess for outcomes. Now, by sheer nature of this course, I think you'll be convinced by the time we're done that half your patients have cancer and the other half has infection. And of course, that's not the case. I will try to put this in perspective as I go through the material. The fact is, the majority of the people that we are seeing, physical therapy is where they belong. But again, in terms of differential diagnosis, we're spending our time at phase one, that initial phase where we need to make the basic decision: am I going to treat and refer, or refer only? If we look at the Guide to PT Practice, there are multiple statements regarding this responsibility related to consultation with a referral to another provider, and there are a number of statements within the guide. Now, this responsibility didn't start when the guide was first published. We've been screening patients forever. I was taught 38 years ago to ask about night pain, ask about bottom bladder changes for patients with low back pain. This is not a new responsibility. What the guide has done, though, is more clearly articulated the responsibility, and the guide is a public statement. It is used not only within our profession, but also outside of our profession as a way to educate others what constitutes physical therapist practice. One of the things that I'd like to point out, that in this slide and this slide, that when you look at statements regarding this responsibility, there's no mention of direct access or physician referral. There's only one standard of practice. There's only one guide for professional conduct. There's only one code of ethics. And so any statement regarding patient safety, any statement regarding this referral process, it makes no difference how the patient accesses our services. There's only one set of rules and regulations, only one set of practice standards. It also doesn't make any difference whether we're APTA members or not. Consensus standards are used for someone outsider to judge my practice. If a complaint is filed against me, they're going to look at my documentation, they're going to look at my actions and compare it to the State Practice Act, the rules and regulations, any internal guidelines regarding the facility I'm practicing at, and national practice standards. And again, it makes no difference if I'm an APTA member or not. So I know I'm preaching to the choir. The fact that all of you are involved in taking this course, but you're going to have opportunities to spread the gospel here. And it's just important for people to understand that this responsibility transcends APTA membership. It transcends how the patient accesses our services. It transcends what academic degree we left physical therapy school with. There are some state practice acts that have specific language. Not all, but some do. This is the example that we have here in Wisconsin. And this went into effect by 8 years ago, where we added a statement, duty to refer. And even though we've always had this duty, It was never placed in writing before in any of the rules and regulations or the Practice Act. And with our last Practice Act revision, we were able to get words like diagnosis, differential diagnosis, joint manipulation into our Practice Act, and we felt this was the responsible thing to do. So does this raise the ante? Does this raise the level of responsibility? On paper, yes, but from a moral and practical perspectives, the answer is no. I've always had this duty, I've always had the responsibility, and again, as a profession, we've been carrying it out to a degree. Coming back to our role in a physician's role, and I mentioned this earlier, that a number of the guidelines out there and guidelines that we're going to talk about in this course, most were written for physicians. But when you look at the criteria, they're right up our alley. It's patient information that we would routinely collect. And in many ways, we screen a patient on a body systems level, a physiology level. I'm screening the GI system. I'm screening the cardiac or peripheral vascular systems. I'm not screening for specific diseases. In fact, the majority of the conditions that we're going to discuss in this course, nobody, even a physician, could not diagnose the specific condition simply based on history and physical examination. It takes more than that. It takes advanced blood work. It takes advanced imaging. It takes a biopsy. The joint needs to be aspirated before a diagnosis can be made. Now, a physician, that's their job, to make those types of diagnoses, but they also start screening on the same level that we screen at, and that's the body systems level. But they will take it one step further for the pathological conditions that we're going to be talking about. So again, there's a lot of overlap how we screen, but of course we diverge at a specific point in order for both of us to stay within our scope of practice. There are two readings related to the first segment of this course, and the bottom of this slide in bold, I did an editorial with Catherine Goodman. It's short. It's 3 pages, and there we describe our role in a physician's role and give some additional examples. So if you haven't already, I would maybe hit pause here and breeze through that editorial before we head into the next segments. So I've mentioned we've been doing this screening for decades, since the inception of our profession. Are there any examples of us doing this screening? I did a project with Dr. Michael Ross, who's a physical therapist in the military. We reviewed the literature manually. I went through every single issue of the PT Journal starting from 1921 and JOSPT from 1979, and we did a lit search looking for published case reports and case series where a patient comes to physical therapist does the examination, refers the patient to a physician, and a disease is diagnosed. And this was just published in JOSPT May 2012. So this is the second article that I have listed for this first segment. So reviewing the literature, we found 78 examples, again, of patients coming to physical therapists and the PT's exam leading to a physician referral. One of the things that surprised us as we looked at these cases and tried to draw from them, one, how did the patient access our services? What were the red flags that led to the referral? How were these conditions diagnosed? My assumption had been that a majority of these published cases, the patient would have accessed our services via direct access. And that was my assumption. Yet, upon review of these 78 cases, almost 75% of these patients have been referred to physical therapist by a physician. So the patient saw the physician sends the patient to the physical therapist does the examination, refers the patient back to the physician, and then a diagnosis is made. So almost 3/4, a majority, were seen by a physician first. Interestingly, related to the referred patients, the most common diagnosis that these patients came in with was pain location. So low back pain, neck pain, knee pain, calf pain. There was a cluster where it was pathoanatomy made up the diagnosis. So sciatica, degenerative disc disease, osteoarthritis of the knee, neurogenic claudication. And the referral source for the referred patients, primary care physician, the family practice physician, and orthopods were the top groups of where these patients came from. Regarding ultimately the diagnosis for these 78 patients, not a big surprise since the majority of these patients were seen in outpatient ambulatory settings. There was a neuromusculoskeletal condition, fractures, infections, neuropathies, nerve injuries, systemic processes like rheumatoid arthritis or ankylosing spondylitis. 22% ended up being visceral disorders. So heart, lung problems, urogenital problems, and then there's a smattering of miscellaneous conditions, other cancers that didn't fit under neuromusculoskeletal or visceral conditions. 3 cases, medications, adverse events, side effects of medications ended up being the underlying reason for the red flag findings during the examination. And interestingly, considering the nature of the variety of pathological processes that were ultimately diagnosed, the chief presenting complaint for these patients was simply pain. And that's what I mentioned earlier, is that there's a lot of overlap how diseases can present in early and middle stages compared to conditions that we can manage and manage well. So for many pathological processes, the chief complaint is pain, aching, stiffness, soreness, some weakness, pins and needles, numbness. And these are very, very common complaints that we see in our major patient populations. What was also interesting, I had assumed that in the majority of cases the referral from the physical therapist would have happened at the initial visit. And in fact the majority did, but almost a quarter of the patients were referred at a follow-up visit. And the mean time frame for that referral to take place was 2.5 weeks within the initial visit. What this illustrates is that we screen patients not only at the initial visit, but we are vigilant for new findings, unexplained worsening of patients' conditions that transcends that initial visit. And so you can see in the bullet under the third dash is that no improvement of the chief complaint, unexplained worsening of the chief complaint, and onset of new concerning complaints makes up the reasons for the referral at visit 2 or 6 or sometimes 8. And part of this comes back to what I mentioned before, is that disease has its own timetable in terms of when it's going to present. This also illustrates that these physical therapists did a good job of establishing a prognosis at the initial visit, and that prognosis was not being met, and in a way that the therapist was uncomfortable going on with further care. Also, what was interesting in review of these cases is that in almost 25% of the cases, it was the physical therapist that referred the patient directly for the medical tests, and this is for the imaging. And not all these patients were seen in the military system. Some were, but not all. And so physical therapists working collaboratively with radiologists and then back to the patient's primary care physician, or if they had seen an orthopedist in the past, for further diagnostics and medical management along with the physical therapy management. So here's the citation, and again, if you haven't, I would maybe pause here and breeze through this article. The last part of this segment, I want to give you some examples. So how can these patients end up in our laps? I mean, how does that happen? There's a really nice feature in JOSPT called musculoskeletal imaging. It started in 2008. And you don't find this feature, these articles, in every single issue, but they're in most issues these days. And sometimes there's 2 or 3 in one issue. They're very short, a page, 2 pages maximum. You get a couple paragraphs about the patient themselves, and then you get pictures of imaging. And what's a really nice feature for through JOSPT is that you can download the slides of the images. So you can turn these into a really nice in-service or presentation ready-made. So here's a situation. Patient was 34 weeks pregnant, about 4 weeks before she saw the physical therapist, developed some mild low back pain. It wasn't getting better, so she went to see her physician. And she saw the physician 1 week before seeing the physical therapist. So the patient was referred to physical therapy with a diagnosis of mild low back pain. So that's what the therapist knew heading into this visit. The therapist goes out to the waiting area to get the patient, and she's in a wheelchair, which the therapist wasn't expecting, based on information from the physician. The therapist wheels the patient back, asks about the wheelchair, why, and what the patient describes that in just the last couple of days she started experiencing some numbness in both legs, weakness, heaviness in both legs. She's able to walk, but it's difficult. And then upon further questioning, the patient reveals that she has been wetting herself, losing urine. Now, you would think anybody out in the public who developed recent numbness in both legs, weakness in both legs at the point of needing a wheelchair, and wetting their pants, that they would go see a physician. But this patient came to the physical therapist. Another point here is, patient who presents that way, how long do you think this patient examination took? Matter of minutes. I mean, how much more do you need to know from this patient, except a basic question: patient, have you contacted your physician to let them know about these new complaints? And the patient response here was no. So the physician's unaware, patient hasn't reported to anybody. This is a really short examination. So the physical therapist referred the patient, working with the radiologist, to. And here's a sagittal view, and you can see where that arrow is pointing that we have an extruded disc, and you can appreciate the stenosis or narrowing. You can see the dark tube, the thecal sac with cauda equina, and how much space there is for it above the extruded disc. And the next slide, here we have the axial view, and again the arrow points to the disc extrusion. Doesn't look quite as dramatic in this view as the sagittal view, but you can appreciate how it's just pushing the thecal sac up against the posterior arch, ligamentum flavum, and the lamina. So this becomes an urgent surgery. Thankfully, the surgery was successful. The patient got full neurologic return and carried the pregnancy full term. Another example, this was a patient who was out running 4 weeks ago and rolled over her ankle, an inversion sprain. And here 4 weeks later is still having ankle pain, still unable to run. And went to see a physician. She was referred for plain films. Plain films were done, read by the radiologist as negative. So the patient comes in to see, then referred to physical therapist, coming with a diagnosis of ankle sprain. So physical therapist takes the history. Here's the story that I just gave you. In the physical exam, ankle and foot range of motion within normal limits, not painful. The only findings were antalgic gait and pain with palpation. And the site of palpatory pain was just proximal to the lateral malleolus, where it's pretty clear that the therapist was on bone. Now the concern was, if this was a bony lesion and potentially a fracture, could it be related to her history of breast cancer? Could this be metastasis or not? So here's the plain film. So the therapist looks at the plain film, and of course at that time the arrow's not there. The arrow's just there for publication. Now with the arrow there, which makes it a little easier, I think you can maybe see at that distal end of the shaft of the fibula, there's a horizontal white line. There's a little bit of a bump, enlargement. And this happened to be where the patient was painful, tender, with palpation during the therapist's clinical exam. So again, with the patient's history of breast cancer, advanced imaging was requested. And bone scan we'll look at first. And again, the toes are pointing down toward the floor. You can see the bottoms of the feet are together, and the bright spot is the hot spot. Bone scan is an excellent modality for picking up early changes in bone. It doesn't tell you what's wrong, but tells you something is wrong. And so this points to bone. Could there still be metastasis is the concern. So an MRI is done, and section A of this slide is probably the easiest. And again, you look at the arrow, you can see that horizontal line, a fracture line. Now the good news is this is not a pathological fracture. It is unrelated to the history of breast cancer. So here's a situation where patient sees the physician, is sent to radiology, plain films are taken, the red is negative, but the therapist did a good job of sticking with the findings of the physical exam and followed up with the radiologist and physician for the diagnosis to be made. One more example and a really brief overview. You have this citation in your reference list that I will direct you to shortly. So as a patient, again, saw a physician 4 weeks before, mild hip pain associated with X amount of walking. Plain films were taken, mild osteoarthritis was the diagnosis. Patient comes to see a physical therapist 4 weeks later. She's using a walker with significant severe gait antalgia. That was not there when she saw the physician. The physical therapist hears no explanation for the sudden worsening of this hip pain. Patient presents with significant range of motion losses of that right hip, and pain provoked with active movements and combined movements, enough so that the therapist refers this patient back to the physician where MRI is done, and the arrows point to two fracture lines at the head of the femur and the neck of the femur. And you can also appreciate areas of increased signal intensity if you look at that right proximal femur compared to the left, the uninvolved side. So thankfully, this patient was diagnosed soon enough and managed appropriately that she did not need surgery. So yet another example of a patient seeing a physician. The major red flag warning signs are not there when she saw the physician. Again, disease has its own timetable. A couple more slides in this segment here. If you look on the left-hand side of the slide, you have a flow chart. This is the classic medical model. How does our screening fit into the classic medical model? So we have occult disease. That means the disease is there, but it has not yet been diagnosed. And that can happen for a variety of reasons. Now, there are, thankfully, a number of bugs, diseases that we all get that are self-limiting. The body can take care of it, the body can fight it off, and life is good again after a few days or a week or two. But of course, that's not the case for all diseases. There are a number that once they're diagnosed, they need medical treatment in order for there to be any hope for resolution of that disease process. So the symptoms and signs get overt enough, severe enough, the disease is finally diagnosed. Then of course the big question is, what does it mean for that patient in terms of morbidity and mortality? So the goal of our screening process is to shorten the time frame from when that disease begins and when that disease is diagnosed. And give you an example that we're going to go into more detail in the next segment here is cancer and low back pain. The literature consistently shows that the initial presenting complaint is simply a dull ache, and it can be mild and intermittent in early stages. But of course that ache is only going to get worse as the cancer worsens. The literature suggests that the average length of time from when that cancer backache begins and that tumor is finally diagnosed, the average length of time is 9 months. The range is huge, 1 to 30 months, but 9 months is the average length of time. So if we do our job well at screening and we can shorten that time frame down to maybe a mean of 4 months or 3 months, that could potentially make a big difference in morbidity and mortality. And that's the goal of our screening process. Now, we will not be the ones that are diagnosing the tumor. Again, as mentioned earlier, nobody, not even a physician, can diagnose a tumor simply based on history and physical examination. It's going to take advanced imaging. It's going to take blood work. It's going to take a biopsy. And that's what physicians do. But we contribute to the diagnosis being made by getting the patient to the right practitioner in a timely fashion. So that takes us back to the slide we were looking at earlier. So again, the fork in the road. Any patient, no matter how they access our services, any patient we are screening. And we have 3 choices to make at every single visit. Am I comfortable? If the answer is yes to that, I'm going to treat. If I'm uncomfortable, then I'm going to either treat and refer or refer only, and that decision is based on what am I concerned about and how urgent might the health status, the patient health status be compromised. The urgency of that compromise is going to drive my decision. So this fork in the road, it's not designed to make us mini physicians. It's just doing our examination, doing it well, and recognizing those who need to see a practitioner other than a physical therapist. Related to this information, you have in Appendix 1 a couple long reference lists. You have the patient case reports in series that I summarized along with Michael Ross. The reason for providing you all those cases, no matter what practice setting you're in, whether it's inpatient, outpatient, acute care, adult neuro rehab, pediatrics, orthopedics, sports medicine, women's health, you can find at least one case that fits your practice setting and patient population. And as I mentioned earlier, these cases, the way they have to be written to be published, make really good teaching tools and really good learning tools. Basically, you can put on the shoes of that clinician. You can put on that detective hat of that clinician. And how would you have interpreted that patient history and physical examination? And you can compare to the decision making of the clinicians. And then the last segment of these case reports and series is the bottom line. What did the patient end up having? What is the gold standard for diagnosis? What are diagnostic tests that are not gold standards that can help us in terms of how comfortable or uncomfortable can we be with medical tests that are done? Also within this Appendix 1 you have a number of references that describe the clinical guidelines that are out there, and we will cover most of those in this course. And then there also are some references related to direct access practice. So the screening process does not only apply to direct access setting, but it is certainly tied to direct access. And patient safety is almost always brought up by others who may be in opposition to direct access. So those references may be helpful to you as well. So again, this was that last objective that I talked about. My goal is to make sure that you have resources above and beyond this CD related to this material.